Okay guys, my name is Dr. Mohammad Wajid Khan. I'm an anesthetist and intensivist. So guys, we will be dealing with this topic of anesthesia, starting with this topic of general anesthesia. Right, we'll start with this topic of general anesthesia. Now in general anesthesia, what we need to know is, first we need to know the indication of general anesthesia. We have already discussed the indication, guys. What's the indication of general anesthesia? General anesthesia is indicated for the surgeries which are done above the level of umbilicus. Above the level of umbilicus. It could be major surgeries or it could be any surgery, but the surgery which is done above the level of umbilicus, the anesthesia that we need to give is called as general anesthesia. For any laparoscopic below umbilicus surgery also you have to go for general anesthesia. Why? Because in laparoscopic surgery, we use a gas called as carbon dioxide to insufflate the abdomen, which usually irritates the patient. So we have to go for general anesthesia. So the main indication is above umbilicus surgery. Above umbilicus surgery, you have to go for general anesthesia, right? Now guys, in general anesthesia, before taking the patient into the operation theatre, we take the patient into a pre-op room. Before giving general anesthesia, and again before starting anything, we take the patient into a pre-op room. Imagine guys, this is the operation theatre. Here will be the pre-op room, and after surgery the patient will be shifted to a post-op room, right? So in the pre-op room, we take the patient and we give some pre-medications. We give some pre-medications. What pre-medications we give in the pre-op room? The pre-medications that we give in the pre-op room are nothing but 4 A's. 4 A's we give. And we give 4 pre-medications which are starting with the alphabet A. Starting with the first pre-medication called as anti-anxiety. Next is anti-emetic. Third is anticholinergic. Fourth is antibiotic. Right guys? Right? So we are starting with the 4 pre-medications or 4 A's. Anti-anxiety, anti-emetic, anticholinergic and antibiotic. The first A is what guys? The first A is anti-anxiety. In anti-anxiety, the drug of choice. First of all, why are you giving anti-anxiety? Till date, most of the patients, when you tell something about surgery, they will be scared about surgery. Right? Many of the patients are scared about surgery. So to reduce the anxiety related to surgery, to reduce the stress related to surgery, what we do is we give the patient pre-medication as first A, which is anti-anxiety. The drug of choice is what guys? The drug of choice is lorazepam. First A is anti-anxiety. The drug of choice is lorazepam. Anti-anxiety, the drug of choice is lorazepam. The second A, first A we have discussed. The second A was what guys? Anti-emetic. Anti-emetic. Anti-emetic yani ki this is the drug that usually prevents the risk of regurgitation and all, right? In anti-emetic, you are having most commonly used and most potent. The most commonly used anti-emetic drug is metoclopramide. Metoclopramide is the most commonly used anti-emetic drug. But the most potent drug is what? Hyoscine. We were talking about anti-emetic. Why do you give anti-emetic to a patient? Anti-emetic is given to prevent the regurgitation. The most commonly used anti-emetic is metoclopramide, but the most potent is hyoscine. The third is anticholinergic. Why do you give anticholinergic to a patient? Anticholinergic is given to decrease the incidence of formation, to decrease the formation of saliva. Anticholinergic, right? Sometimes the patient might aspirate his salivary secretions. To decrease the incidence of aspiration of salivary secretions, we give anticholinergic medication. Anticholinergic. In anticholinergic, there are two medications. One medication is atropine, other is glycopyrrolate. Which anticholinergic will you choose? Atropine or glycopyrrolate? Which one guys? The drug of choice remains glycopyrrolate. Why not atropine? whether it is glyco or whether it is atropine, both will cause what? Both will decrease the salivary secretions. But atropine with decreasing the salivary secretion, it increases the heart rate much, whereas glycopyrrolate increases the heart rate a bit only. Glycopyrrolate increases the heart rate a bit only, right? So remember, due to this, what we give, guys? Due to this, the drug of choice remains what? It is glycopyrrolate. So 3 A's. First A is anti-anxiety. Second A is anti-emetic. Third A is anticholinergic. Fourth A is antibiotic. You have to give this antibiotics before surgery. Why are you giving this antibiotic before surgery? To prevent the risk of nosocomial infections. Sometimes the surgeon's hand is not sterile or the gloves are not sterile. Sometimes the nurse gloves is not sterile, the nurse who is assisting the case. Sometimes the operation theater might be not sterile, and patient might get infection due to the non-sterility of it. So what we do, guys, we give them antibiotics to prevent nosocomial infection. The best time to give antibiotic is come on guys, what's the best time to give this antibiotic? It is 20 to 30 minutes before surgical incision. It is 20 to 30 minutes before surgical incision. All can be safely given. In the antibiotics, what we need to remember is all antibiotics are safely given except two. Two antibiotics are avoided. Two antibiotics are avoided before surgery. What two antibiotics? Aminoglycoside and tetracycline. Aminoglycoside and tetracycline. Why are they avoided, guys? Why? Because they also cause the same effect what lithium was causing in anesthesia. Lithium was also avoided 24 hours before surgery. Yes or no? Why? Because it was prolonging the effect of muscle relaxant. Aminoglycoside and tetracycline they also prolong the effect of muscle relaxant. Two antibiotics are avoided as they prolong the effect of muscle relaxant. Right? This is regarding what? This is regarding the pre-medications. Once again, guys, in pre-medications, we are giving 4 A's to the patient. The first A was anti-anxiety. The second A is anti-emetic. The third A is anticholinergic. And the last A is antibiotic. Right? After giving the 4 pre-medications to the patient, we shift the patient into the operation theater, and now we give what? Now we give general anesthesia to the patient. This general anesthesia, remember guys, this general anesthesia is given in 4 phases. There are 4 phases of general anesthesia. The first phase of general anesthesia, come on guys, we are talking about general anesthesia. It is the only anesthesia technique where the patient is to be made unconscious. General anesthesia is indicated usually for above umbilicus surgeries. Okay. So anyways, what are the 4 phases? This general anesthesia can be given in 4 phases. The first phase of general anesthesia is called as pre-oxygenation. The second phase of general anesthesia is called as induction phase. The second phase is called as what, guys? Induction phase. The third phase of general anesthesia is called as, after induction, the third phase is called as what? The maintenance phase. The third phase is Maintenance phase. And the last phase of general anesthesia is called as what? The reversal phase. It is called as a reversal phase. There are 4 phases of general anesthesia. In these 4 phases, you make the patient unconscious, and in the last phase, you make the patient conscious. So anyways, guys, so if you want to give general anesthesia to the patient, these are the 4 phases. Now you might be seeing the pictures of flight over here, right? We anesthetists usually refer general anesthesia is like flying an aeroplane. We tell it as what? General anesthesia is like flying an aeroplane. And when you fly an aeroplane, again there are 4 phases of aeroplane. The first phase of the aeroplane, remember we have just compared, we are first discussing the phases of aeroplane, then we'll compare all the phases of aeroplane with general anesthesia. The first phase of aeroplane is what? It is basically once you step into the aeroplane, it basically taxis around the runway. It taxis around the runway. The most important phase is that phase. The most important thing that happens in that phase when it is standing still and all is refueling. The aeroplane is being refueled. The first phase is taxiing or the refueling of the aeroplane. Once the refueling is done, the second phase of the aeroplane is, now the aeroplane is about to take off, the takeoff phase. After takeoff phase, the third phase of the aeroplane is maintenance phase. It will maintain itself in the mid-air. It will maintain itself in the mid-air. And once the journey is completed, the last phase of the aeroplane is what? The landing phase. The last phase is the landing phase. Coming to the first phase. First phase was pre-oxygenation. When you compare the phases of aeroplane with humans, the first phase of aeroplane was refueling. In humans, we refuel them with oxygen. The first phase in humans in general anesthesia is what? Pre-oxygenation. You pre-oxygenate the patient for, we pre-oxygenate the patient for 3 to 5 minutes with 100% of oxygen. With 100% of oxygen. That is the first phase. Second phase of the aeroplane was what, guys? The takeoff phase. When you compare the takeoff phase with general anesthesia, this, remember, the second phase of aeroplane was takeoff. In general anesthesia, it is called as what? Induction phase. Induction phase. Right? Then the third phase of aeroplane was maintenance. In general anesthesia, it is also maintenance. And the last phase of aeroplane was landing, which is called as reversal phase. Right? Now coming to the induction phase. What should be your aim in the induction phase? There are 3 aims in the induction phase. There are 3 aims in the induction phase. The first aim is what, guys? The first aim in the induction phase is, come on, we are talking about general anesthesia. What should be your aim in general anesthesia? The first aim should be, I should make the patient unconscious. I should make the patient unconscious. The second aim should be, I should make the muscles relax. I should make the muscle relax. Now patient is like a dead body. Yes or no? The similarity between a murder and general anesthesia is what? In a murder also you make a person unconscious and initially his muscles will be relaxed. In general anesthesia also you make the patient unconscious and initially you make the muscles relax. But the difference between the murder and general anesthesia is what? In murder you leave the person to die, whereas in general anesthesia, now he is like a dead body after achieving these 2 aims. The third aim should be what, guys? Intubate and ventilate the patient. Intubate and ventilate the patient. Right? We are talking about what phase? We are talking about the second phase, which is called as what phase? Induction phase. Induction phase. These are 3 aims of the induction phase. Now guys, look over here. We are talking about induction phase. The 3 aims are, if you remember the induction phase aims, you can easily remember the maintenance as well as reversal. right? The first aim is make the patient unconscious, second is make the muscle relax, third is intubate and ventilate. Once induction phase is done, you go towards the what phase? Maintenance phase. The third phase of general anesthesia is maintenance. Yani now the flight has taken off. Now it has to maintain itself in the mid area. Yani now you have started general anesthesia. Now just you have to maintain it. So in the maintenance phase, what are the three aims? In the maintenance phase, what are the three aims? What are the three aims of the maintenance phase, guys? The first aim of the maintenance phase is maintain the patient unconscious. Maintain the patient unconscious. The second aim should be basically maintenance mein what you need to write instead of make. In the induction phase you are writing make, no. Instead of make you have to remember maintain in the maintenance phase. Second aim would be what, guys? Maintain the muscle relaxation. Maintain the muscle relaxation. Once you have achieved these two, the third aim is will be what? Now don't tell me again, sir, I will intubate. Already intubated. What do you need to do? Just maintain the ventilation. Just maintain the ventilation. In the maintenance phase, maintain the patient unconscious, maintain the muscle relaxation, and maintain the ventilation. What is the last phase of general anesthesia? The last phase of general anesthesia is called as reversal or recovery phase. Okay? Or in the flight or airplane, we call it as what? It is called as a landing phase. Right? So, the last phase is reversal or recovery phase. In the reversal phase, what is your aims? In the reversal phase, you have again three aims. Again, guys, induction phase mein what was the aim? Make the patient unconscious, make the muscles relax, intubate and ventilate. In maintenance phase, maintain the patient unconscious, maintain muscle relaxation and maintain ventilation. Surgery is done. Now you should do what? Make the patient conscious. Make the patient conscious. Once you make the patient conscious, the second aim would be what, guys? Make the muscles contract. Make the muscles contract. And now the surgery is done. Now you have to remove the endotracheal tube. So third aim in the reversal phase would be what? Extubate the patient. Extubate the patient. Once again, there are four phases of general anesthesia. The first phase is what? Pre-oxygenation. Second phase, induction. Third, maintenance. Fourth, reversal or recovery. Right? So anyways, guys, we have discussed about pre-oxygenation. Now we will discuss about the induction phase. The first aim in the induction phase is to make the patient unconscious. How will you make the patient unconscious? You make the patient unconscious. If it is an adult, you make him unconscious by using IV induction agents. IV induction agent. Right? For adult, you make them unconscious by using IV induction agent. But if it is a child, then how will you make the child unconscious? If it is a child, you make the child unconscious by, remember guys, children are the ones who are creating nuisance to put an IV cannula. IV induction agent can be given if you put an IV cannula. But if you don't have an IV cannula, how will you put an IV induction agent? It's not possible. So remember guys, in a children or in a child, if you did not put an IV cannula, then you can go for what induction? In children, instead of giving IV induction to make them unconscious, you can use inhalational induction. You can use what, guys? Inhalational induction. The inhalational induction agent of choice is the sweet odor sevoflurane. The inhalational induction agent of choice is what, guys? Sweet odor sevoflurane. This is very, very important. There are many inhalational agents. Halothane, isoflurane, like methoxyflurane, nitrous and on, many are there. But for children, inhalational induction in children, we are using a sweet odor sevoflurane, which is having a fruity odor. Okay, why? Because it's have a sweet odor. Next, what is the next aim? Once you make the patient unconscious, the next aim is you have to make the muscles relax. How will you make the muscles relax? You make the muscles relax by giving short-acting muscle relaxant. By giving short-acting muscle relaxant. There are two kinds of muscle relaxant, guys. One is long-acting, one is short-acting. Which one will you choose before intubation? Always remember, guys, before intubation, always give a short-acting muscle relaxant. Why? If at all you fail to intubate also, the patient won't die. Why? Because your muscle relaxant is acting only for a short time. Okay? But if you give a long-acting muscle relaxant, then it becomes your bloody responsibility to intubate this person. If you don't intubate after giving long-acting, you will be basically committing a crime. Okay? So remember, you give a muscle relaxant, which is what? Long-acting or short-acting? You give a short-acting muscle relaxant and then you intubate and ventilate the patient. So in the induction phase, you make the patient unconscious by IV induction. If it is a child, you make him unconscious by inhalational induction. Second is you make the muscle relax. How will you make the muscle relax? Long-acting or short-acting? You make the muscle relax by giving short-acting muscle relaxant. Then you intubate and ventilate. Once induction phase is done, what is the next phase that we need to cover? The next phase is maintenance phase. Maintenance phase. In the maintenance phase of general anesthesia, what should be your aim, guys, in the maintenance phase of general anesthesia? We have already discussed the aims. The aim is what? Maintain the patient unconscious. Now don't tell me that. First of all, tell me, how will you maintain the patient unconscious? To make the patient unconscious, you are using IV induction agent. Propofol, ethomidate, thiopentone, ketamine are the examples of IV induction. Any one of the four you will use. But how will you maintain the patient unconscious? Your IV induction agent works for only 10 minutes. Will you repeat the doses of IV induction agent and give it to the patient? No. Top-up doses are only allowed in epidural, not for general or spinal, right? So remember, guys, how will you maintain the patient unconscious? It is not by IV induction, it is by inhalational agents. It is by inhalational agent. The main function of inhalational agent is to maintain the patient unconscious. The main function of the inhalational agent is to maintain the patient unconscious, right? Next, once you have maintained the patient unconscious by inhalational agent, the next thing is what? You maintain the muscle relaxation. How will you maintain the muscle relaxation? Will you give a short acting or will you give a long acting? Think, guys. Will you give a long acting or short acting? Short acting is always given before intubation. Now the patient is already intubated. Now you can give a long acting or intermediate acting muscle relaxant. Long or intermediate acting muscle relaxant according to the surgery. So you maintain the muscle relaxation by giving long or intermediate acting muscle relaxant. Third aim is what? You maintain the ventilation. Third aim in the maintenance phases, you maintain the ventilation. Once the maintenance phase is done, what is the last phase of general anesthesia? The last phase of general anesthesia is called as the reversal or the landing phase. The reversal or the landing phase. What are the three aims in the reversal phase? The first aim is what? The surgery is done now. Now you have to wake up the patient. The first aim should be make the patient conscious. How will you make the patient conscious? Will you tell the patient, please wake up? No. How will you make the patient conscious? You make the patient conscious by stopping the inhalational agent. What was the thing that was maintaining him unconscious? Inhalational agent. Stop the inhalational agent, he will be conscious, but still he is not able to open his eyes. He is not able to move even though he is conscious. Why? Why? Because in the maintenance phase you give a long or intermediate acting muscle relaxant. So second aim is you have to make the muscles contract. How will you make the muscles contract? By stopping the muscle relaxant and giving a reversal agent. you have to give a reversal agent against muscle relaxant. What is the reversal agent used against muscle relaxant called as? That reversal agent is called as neostigmine. That reversal agent is called as what, guys? Neostigmine. If you give plain neostigmine to the patient, it will cause muscle contraction. At the same time, it will cause bradycardia. If you give plain neostigmine, what will it cause? It will cause muscle contraction. With muscle contraction, muscles will be contracted, but the patient will have bradycardia. So we give neostigmine with either atropine or either glycopyrrolate. Okay? So that the patient won't have bradycardia. Plain neostigmine is not given. It's a reversal agent given against muscle relaxant, but plain is never given. If you give plain neostigmine, patient will have bradycardia. So we give what? Neostigmine with either atropine or glycopyrrolate. Once the muscles have contracted, now the patient will be moving, he'll be opening his eyes and all. Now you have to remove the tube. The third, the last aim of the landing phase is you remove the endotracheal tube, yani you extubate the patient. You extubate the patient. Once again, guys, we are talking about general anesthesia 4 phases. Please, general anesthesia 4 phases, please just look over here. First phase is pre-oxygenation, the second is induction, third is maintenance, fourth is reversal. In the pre-oxygenation, pre-oxygenate the patient for 3 to 5 minutes with 100% of oxygen. In the maintenance phase of general anesthesia, how will you maintain, in the induction phase of general anesthesia, you make the patient unconscious, make the muscle relax, intubate the patient. Okay, you have to make the patient unconscious, IV induction. If it is a child, inhalational. Which is the agent? Sevoflurane. Second, you make the muscle relax by short acting, then you intubate. Once the induction phase is done, the third phase is maintenance phase. 3 aims of maintenance is maintain unconsciousness by inhalational agent, maintain muscle relaxation by long acting, maintain the ventilation. Last phase is the reversal phase. In the reversal phase, 3 aims are make the patient conscious by stopping inhalational agent, make the muscles contract by giving a reversal agent against muscle relaxant, and last aim is extubate the patient. Last aim is what, guys? Extubate the patient. So these were the 4 phases of what anesthesia? General anesthesia. Now guys, I'll give you a case. You guys tell me what will you do if you are there in that scenario. The case over here, what we need to discuss is, imagine a patient is there who's coming from a wedding on a bike. Okay? A person is there who is going to his home from the wedding on a bike. He meets with a road traffic accident. He develops a head injury and he is being diagnosed with intracranial bleed. He's being diagnosed with what, guys? Intracranial bleed. Right? Now, as the patient is shifted to the hospital, the neurosurgeon is telling that I will do the surgery as soon as possible. I'll go for a craniotomy, a decompressive craniotomy. Why? Because this patient requires an emergency surgery which needs to be done. Imagine I am the surgeon and you guys are the anesthetist. I'm calling you and telling you, give anesthesia to this patient. I'll go for the surgery. Which anesthesia will you give, guys? I'm talking about what? Head injury. Okay, surgeon is going for head injury. Head injury means which anesthesia? You have to go for general anesthesia. Major surgery and above umbilicus general. So you go for general anesthesia. But will you tell the surgeon that, sir, he is coming from a wedding, he is full stomach. Guys, there is a rule. When we go to the wedding, we are not only feeding our stomach, we are also feeding our esophagus. We are totally full. When we are coming from a wedding, we are totally full. Yes or no? So will you tell the surgeon that we will wait for 6 to 8 hours, sir? Then only I will give general anesthesia? No. In emergency scenario, you have to give general anesthesia even though you know that general anesthesia is a risky thing that causes aspiration. Even though you know that, you have to go for general anesthesia. You have to go for general anesthesia. So guys, once again, so basically you will be in a dilemma now. General anesthesia causes aspiration. This patient is full stomach. but he's in an emergency. So how will you give general anesthesia in an emergency scenario or to a full stomach patient? General anesthesia given to a full stomach patient is called as RSI. The general anesthesia technique given to a full stomach patient is called as what, guys? RSI. What is that RSI? RSI means rapid sequence induction. Okay? Here the point is given, no? To prevent aspiration in such patients. Who are those such patients? Such patients means what? Such patient means what? Patient at risk of aspiration. Patient at risk of aspiration. I told you guys, there are some patients who are at risk of aspiration. Even though you tell them to be in an empty stomach, still they are at risk of aspiration. Who are the patients who are at risk of aspiration even though they are empty stomach? Who? Obese patient, right? ascites, pregnancy, GERD, hiatus hernia and emergency. The case that I gave you, emergency. Okay? Some of you might be thinking emergency scenario is, sir, we'll put a rice tube, we'll deflate the stomach, but still guys, it doesn't give you 100% of prevention against aspiration. Still there is a risk of aspiration. So guys, if you want to give general anesthesia in a full stomach patient, you have to go for a technique called dash is done. What is a dash called as? Rapid sequence induction. Rapid sequence induction is done. Rapid sequence induction is done. In patients who are at risk of aspiration, a technique called as rapid sequence induction is done. What is this rapid sequence induction? Rapid sequence induction is nothing but general anesthesia given to a full stomach patient. What is rapid sequence induction, guys? General anesthesia given to a full stomach patient is called as rapid sequence induction. It is same like general anesthesia. Same goes with 4 phases. Pre-oxygenation, induction. But we just have to discuss on the induction phase. Why? Because we are talking about rapid sequence induction. What is rapid sequence induction? It is general anesthesia given to a full stomach patient. So this patient is full stomach. How will you give oxygen to this patient? Yani first of all, again like general anesthesia, rapid sequence is also having some phases. Same like general anesthesia. First phase is pre-oxygenation. How will you pre-oxygenate the patient? That is very important. In rapid sequence induction, you pre-oxygenate the patient with 100% of oxygen for 3 to 5 minutes with a normal oxygen mask. With a normal oxygen mask. Why with a normal oxygen mask? Why are you pre-oxygenating the patient with a normal oxygen mask? Why can't you go for bag mask ventilation? Why? Because a normal oxygen mask, when you keep on the patient's mouth, the patient will inhale the fumes of the oxygen. The patient will inhale the fumes of the oxygen, right? And the oxygen will slowly and swiftly goes to the trachea. But if you go for a bag mask, even though you might be giving good amount of oxygen, but if you go for bag mask, you are forcefully pushing. What does bag mask means, guys? Mask is held on the patient's mouth, which is connected through the breathing circuit to a bag, and then you are delivering the oxygen. If you go for bag mask, you are forcefully pushing the oxygen where? Into the trachea, but as you are giving it through the mask, the oxygen can forcefully enter the esophagus also. And as the patient is full stomach, what will happen? The moment the oxygen goes forcefully into the esophagus, the patient will regurgitate and the patient will aspirate. Right? So will you go for bag mask? Never. Bag mask ventilation is avoided. What is BMV, guys? BMV is bag mask ventilation. BMV is what, guys? Bag mask ventilation. Bag mask ventilation is always avoided. BMV is always avoided, or bag mask ventilation is always avoided. Right? Next, apart from that, what else we need to remember? Then we also need to remember that we are discussing about how will you intubate, how will you give general anesthesia to a full stomach patient without causing the risk of aspiration. First step is pre-oxygenate the patient with normal mass. Second, you have to use a fast-acting IV induction agent, any agent. But remember, in the induction phase, your three aims were make the patient unconscious, make the muscles relax, intubate the patient. Here there is slight change. In rapid sequence induction, after pre-oxygenation, you go for induction. But here in this induction, immediately after giving your IV induction agent, you tell your assistant to apply pressure on the cricoid cartilage. Just look over here, guys. You tell your assistant to apply pressure on the cricoid cartilage. Why? As he is applying the pressure on the cricoid cartilage, you can see just beneath the cricoid cartilage is what? Esophagus. You tell your assistant to apply the pressure on the cricoid cartilage so that the upper end of the esophagus is closed and the patient won't regurgitate and the patient won't aspirate. Right? This pressure applied by your assistant is called as Selleck's pressure or Selleck's maneuver or cricoid pressure. Selleck's pressure or Selleck's maneuver or cricoid pressure. When is your assistant applying this pressure? Immediately as the patient is unconscious, and again immediately after giving IV induction, your assistant is applying pressure on the cricoid cartilage so that the upper end of the esophagus is closed. When will you tell your assistant to remove this pressure? When? After intubating the person. But that's not the full answer. After intubating the person, that's not the full answer. My question was, when will you remove the pressure? Imagine, guys, this is the trachea. And this is the endotracheal tube inside the trachea. This is another patient's trachea. And this is the endotracheal tube of that patient. Okay? There are two kinds of endotracheal tube. One is called as cuffed endotracheal tube. Other is called as uncuffed. Which endotracheal tube you will use to intubate this person who is full stomach? You always go for cuffed tube. Why do you go for cuffed tube? Imagine, guys, after intubation, if the patient regurgitates, can the regurgitant material go inside the lungs? No. So remember, guys, you intubate the patient with cuffed tube. My question was, when will you tell your assistant to remove the Selleck's maneuver? Selleck's maneuver is removed after intubation and inflation of the cuff. After intubation and inflate. Once you inflate the cuff will totally block the lumen of the trachea. Cuff will totally block the lumen of the trachea. Now the material won't go inside. Right, guys? So remember, we are talking about what? We are talking about the rapid sequence induction. What are the steps till now we have discussed? In rapid sequence induction is like general anesthesia only. Whether it is general anesthesia or rapid sequence induction, the first step is what? Pre-oxygenation. How are you pre-oxygenating the patient? You pre-oxygenate the patient with normal mask or bag mask. You pre-oxygenate the patient with normal oxygen mask. What is avoided? Bag mask is avoided. Then immediately after IV induction, dash is used. What is a dash? Selleck's maneuver or cricoid pressure is used. Selleck's maneuver or what pressure is used, guys? Cricoid pressure is used. Cricoid pressure is used. That is application of the pressure on the cricoid cartilage in order to block the esophagus. That is called as Selleck's maneuver, right? When are you removing the Selleck's maneuver, right? When are you removing to prevent aspiration in such patient? We have already discussed, guys. RSI, okay? So remember, when are you removing the Selleck's maneuver? You can write there. Selleck's is removed after intubation and inflation of the cuff. After intubation and inflation of the cuff. That is regarding Selleck's maneuver, and that is regarding the general anesthesia introduction. Okay, guys? Thank you.